Hello everyone, in this video we'll be talking about the biological effect of ionizing radiation. So why we need to study biological effects of ionizing radiation? Because X-rays deposit energy in human tissue, causing ionization of atoms and molecules. So we'll be having ionization within our tissues. This deposited energy can damage cells and DNA, potentially leading to biological effects. So this radiation will deposit energy into our tissue, and that will cause biological effects or damage DNA. Understanding these effects is essential to minimize patient radiation risk, protect medical staff for unnecessary exposure, and optimize imaging techniques to achieve diagnostic quality with the lowest possible dose. So the main purpose of understanding biological effect is to minimize radiation risks to the patient and to the staff as well. So the most critical target is DNA. We know that DNA controls cell function and replication. When we have a damaged DNA, the function of our cells will not work as it's supposed to be. So damage to DNA can be repaired or cause cell death or lead to mutation. So be repaired, it will not cause any harm because the cell is already repaired and nothing will change. For the cell death, yes, it can cause functionality loss, and that it may affect the function of the organ itself. But if there is mutation, then it may develop to be a cancer cell or cancer tissue. So now let's talk about the mechanisms of radiation action. We have direct action of radiation. What do you mean by that? When the X-ray photon directly ionizes DNA. When the incident X-ray photon hit the DNA directly and cause damage to the DNA. And we have an indirect action, which X-rays ionize water molecules by ejecting electrons. So the incident X-ray photon will hit the water molecule, causing free radicals, which will cause damage to the DNA. So this is indirect because we are hitting a water molecule, not the DNA itself, and that water molecule will create free radicals that cause damage to the DNA. This ionization produces free radicals, which is highly reactive. Free radicals damage DNA by breaking chemical bonds and leading to strand breaks and base damage. Eventually will cause damage to the DNA. Indirect action is more common in human tissue, so the probability of getting indirect action from radiation is much higher than direct action. Now let's talk about the types of biological effects of radiation. First, we have deterministic effects. It occurs only above a threshold dose, so we need specific dose to be reached to start having deterministic effects. Severity increases with the dose, so as we increase with the dose, the severity or the effect will be higher and higher. As examples, we have skin erythema, cataracts, and radiation burns. So the deterministic effect of radiation, it occurs when we reach a specific dose, and starting from that point we will have that effect, and it will increase in severity when we increase the dose to the patient. It's rare in diagnostic radiography. Why? Because in diagnostic radiography, we don't hit that threshold in almost on all patients, except for a few cases with the fluoroscopy. Now let's move to the next effect, which is the stochastic effect. It has no threshold dose. So even if we have a very small radiation to our body, it will have an impact on producing that effect. So it's mainly about the probability here with this effect. So the probability will increase with the dose. So we can see here from this graph, even if we have a very low radiation here, still there is a probability of getting the stochastic effect. Severity doesn't depend on dose. So the severity of the stochastic effect, it will not be affected by how much radiation we put into the patient. Once we get that effect on the body, increasing the dose will not change its severity at all. So examples, we have cancer and genetic mutations, and the occurrence of this effect is random, and it's the main concern in diagnostic imaging. So for the deterministic effect, it has a very low probability of getting a threshold, but since the stochastic effect doesn't have threshold, it's about the probability. When we increase the dose, we will increase the probability of getting that stochastic effect. So we need to minimize the exposure to the radiation as low as we can. Now let's talk about the radiosensitivity of tissues. Some tissues are more sensitive than others, so this is very important in radiation protection. We know that some tissues are sensitive more than the others. So let's take some examples. Here we have high radiosensitivity, for example, bone marrow, gonads, and thyroid. And some tissues will have low radiosensitivities, such as muscle and nerve tissue. So what are the factors affecting biological damage? We have the total dose. As we increase the total dose to the patient, it will increase the damage to the tissues. And next we have the dose rate. When we increase the rate, when we give a very high dose to the patient within a very short time, this means that we are giving a very high dose rate. Then we have the tissue type. When we expose the thyroid versus muscle, the thyroid for sure it will be affected more than the muscle. And the patient age as well. Younger people will have a higher sensitivity compared to the older. And lastly, the volume of tissue irradiated, which means that if we irradiate more volume to the patient, we are causing more probability of biological damage. What about the dose in diagnostic radiography? The doses are generally low. Deterministic effects are unlikely because deterministic effects needs a threshold or certain dose to be reached to start to see the deterministic effects. The stochastic risk exists, but is small because we are giving low dose to the patient in diagnostic radiography. Risk must always be justified by benefit. So we need to do the justification part before exposing the patient, even for a small dose or small exposure. Every examination must have clinical benefit, and unnecessary exams increase risk without benefit, and justification is a core radiation protection principle. Now let's move to the radiation protection principles. Why the radiation protection is needed? Because X-rays are ionizing radiation, and we cannot see it, smell it, feel it, hear it, and test it. So there is a risk of not seeing something, and this risk needs to be evaluated and justified. It can cause biological effects, and the protection applies to all people, patients, staff, and public. Now let's see the goals of radiation protection. We prevent deterministic effects. We need to prevent it because it's much easier to prevent the deterministic effect by not reaching the threshold, and we reduce stochastic risk because we cannot prevent the stochastic effect since we don't have a threshold. For example, if we give a very small radiation or we expose the public or the healthcare provider to a very small radiation, still it will have that probability of getting a stochastic effect. Ensure benefits outweigh risks. We need to do this justification before hitting the button to expose the patient, and this is very important. Now we have a concept, it's called ALARA. It's as low as reasonably achievable. It means that we give radiation with a minimal dose to produce the image with optimal quality. Those should be minimized in this concept. We should minimize it as low as we can. Image quality must remain diagnostic, so we don't sacrifice the image quality in favor of dose. We need to have that balance of minimizing the dose as we can and get a diagnosable image quality. Applies to both patients and the staff. To achieve ALARA, we need to use time, shielding, and distance principle. So we need to use the three, or we keep in mind these three. So let's talk about these three. We have the time. We need to be less exposed to the radiation by spending less time in the area, so that will reduce the dose. For example, if we can reduce the time, 3 minutes of fluoroscopy time to 1 minute, that will save the patient from a higher dose. And next we have the distance. The dose decreases with distance. This is why we need to be away from the radiation source as much as we can, and this will be calculated through inverse square law. The third part is the shielding, room shielding, and other personal protective materials such as lead aprons, lead gloves, eye shields, thyroid shields, drapes for fluoroscopy, and mobile or rolling shields. These can be used as shielding against radiation, and it will reduce the dose to the staff. So what about how we protect the patient? We can protect the patient by proper collimation. We close the collimation to include only the area of interest, as this example here. Appropriate exposure factors. We don't go with a high exposure factors or unnecessary exposure factors that may increase the dose to the patient. Use of shielding when indicated, and this can be used for area that's not covered or not needed in our image. avoid unnecessary repeats. This is why we need to explain the procedure to the patient before hitting the exposure button. Now we have the occupational monitoring, how we can monitor our healthcare providers. We can monitor them by personal dosimeters, for example, TLD or OSL. They are devices worn by radiation workers that measure the amount of ionizing radiation they are exposed during their work. So this device will measure radiation exposure to the healthcare provider or to the radiation workers. We have monitor accumulated dose over a long period of time. They record the total radiation dose received over weeks or months rather than a single exposure, allowing assessment of chronic exposure. We also measure them over months or even years to assess the risk or to assess the chronic exposure of radiation. Ensure compliance with dose limits. The recorded doses are compared with the regulatory dose limits to verify that workers remain within safe exposure levels and that radiation protection practices are effective. This is why we monitor the radiation workers, because we want to make sure they are not putting them in dangerous situation and they are following the dose limits of the regulatory dose limits. Here we have some examples of regulatory organizations. For example, here we have the ICRP, International Commission on Radiological Protection. We have IAEA, and also some countries has its own national regulatory bodies. For example, here in Saudi Arabia, we have NRRC. And the main role of these regulatory organizations is to provide guidelines and limits. Here we have an example of the NRC limits in Saudi Arabia. We can read the limit for the public exposure workers within the radiology department or radiation workers, and we can follow these limits. And that's it for today's lecture. I'll see you in the next one.